Welcome to The Funnel Effect. Today we are exploring a landmark study from the New England Journal of Medicine, published September 10, 2009, titled The Ticagrelor versus Clopidogrel in Patients with Acute Coronary Syndromes. This research was authored by Lars Wallentin, Richard C. Becker, Andrzej Budaj, Christopher P. Cannon, Håkan Emanuelsson, Claes Held, Jay Horo, Steen Husted, Stefan James, Hugo Cadis, Kenneth W. Mahaffey, Benjamin Sisirka, Alan Skeen, Philippe Gabriel Steg, Robert F. Story, and Robert A. Harrington for the Plato investigators.
Quite the lineup of investigators, honestly.
Yeah, I mean, it's a massive team. But before we get lost in the weeds of all those names, let's set the stage for you, the listener. Imagine swallowing a pill that is, mathematically proven to save your life during a massive heart attack.
Right, which sounds incredible.
It does, but then you read the fine print, and this same pill simultaneously increases your risk of bleeding to death inside your own brain by 11 times.
Yeah, that is the terrifying part.
Exactly. So today we are dissecting how doctors actually navigate that terrifying mathematical tightrope. We're doing a deep dive into a diagnostic and therapeutic landscape that basically forces us to balance these invisible competing risks on a microscopic scale.
It really is the absolute definition of clinical muddy waters.
Yeah.
And, that is exactly what makes the Plato study so incredibly vital to modern cardiovascular medicine.
Right.
Because this isn't just a simple comparison of two drugs going head-to-head in a lab somewhere. I mean, it's a masterclass in how pharmacology iterates to solve complex biological problems, specifically dealing with the chaotic environment of a rupturing plaque inside a coronary artery.
So our mission for this deep dive is to decode the mechanics of that very trial. We're going to bypass the basic biology like we all know what a heart attack is, and instead we are going to look under the hood at the complex pharmacokinetics of these drugs.
Yeah, the real molecular plumbing of it all.
Exactly. We're going to explore the sheer logistical mountain of designing a massive global trial and unpack those deeply nuanced, highly mathematical trade-offs between, preventing clots and causing catastrophic bleeds.
And to really understand the gravity of the Plato trial, we kind of have to start by looking at the medical landscape immediately prior to 2009.
Okay, set the scene for us.
So the clinical focus was squarely on acute coronary syndromes, or ACS. We're talking about patients presenting with unstable angina, non-ST elevation myocardial infarctions, and those massive artery-occluding ST elevation myocardial infarctions.
Right, the STEMIs. So let's contextualize that presentation for everyone. A patient rolls into the emergency department. They aren't just having chest pain, their electrocardiogram is showing distinct ischemic changes.
Right, like profound ST segment elevation.
Yeah, or deep T-wave inversions. Their blood work is showing a massive troponin leak, which tells the doctors that myocardial tissue is actively necrosing. Dying, basically.
Exactly. It is a true ticking clock emergency.
Mm-hmm.
And prior to 2009, the clinical practice guidelines for treating these specific patients were heavily standardized around something called dual antiplatelet therapy.
DAPT.
Yes, DAPT. It was the undisputed cornerstone of acute cardiovascular care. And the rationale is actually pretty straightforward. When a cholesterol plaque ruptures inside a coronary artery, it exposes the highly thrombogenic subendothelial matrix.
Basically the raw, damaged wall of the blood vessel.
Right. And platelets instantly recognize this damage. They activate, change shape, and begin rapidly aggregating to form a plug.
Because they think they're fixing a leak.
Exactly. But in this case, the plug blocks the entire artery.
Yeah.
So to stop this life-threatening cascade, the standard of care was to hit the platelets from two entirely different angles. First, with aspirin, which irreversibly inhibits the COX-1 enzyme.
And second?
Second is with a drug called Clopidogrel, which blocks the P2Y12 receptor on the platelet surface.
Okay, let's unpack this. Because Clopidogrel had been the reigning champion for years, right? The guidelines mandated it, doctors trusted it, and the data showed it absolutely reduced mortality and recurrent infarctions.
It was a blockbuster drug, no question.
But delving into the pharmacological literature from that era, you start to see the cracks in the armor. Because Clopidogrel has a massive biological Achilles heel. It is a prodrug.
Yeah, and that prodrug status is really the crux of the whole issue.
Explain how that works.
Well, when you ingest Clopidogrel, the molecule itself is completely inert. It literally has zero effect on your platelets.
Wait, zero. So it's basically a sugar pill when it hits your stomach.
Pretty much. It must be absorbed from the gut, travel through the portal circulation directly to the liver, and then undergo this complex two-step biotransformation process.
Ah, so the liver has to do the heavy lifting.
Exactly. It's driven by the hepatic cytochrome P450 enzyme system, specifically the CYP2C19 isoenzyme. Only after this hepatic processing is the active metabolite released back into the systemic circulation to actually do its job.
Okay, I like to think of clopidogrel's prodrug mechanism as a sluggish factory line.
That's a great way to put it.
Right. You have to wait for the raw materials to be processed by these specific liver enzymes before the final product actually works to stop the clots. But mechanistically, this presents two glaring problems in an emergency room setting.
Huge problems.
First is just the sheer pharmacokinetic delay. You have an active, expanding thrombus threatening a patient's life right now, but you are relying on a complex biological supply chain to fix it.
Yeah, the precursor has to be shipped to the liver, processed by the CYP enzymes, and shipped back out. It takes time.
But the second problem, which seems far more insidious, is the extreme genetic variability of that CYP2C19 enzyme across global populations.
Oh, the variability is staggering. We discovered that a significant percentage of the global population actually carries loss-of-function alleles for the CYP2C19 gene.
Meaning their factory line is basically broken.
Or at least running on a skeleton crew. These patients are classified as poor metabolizers. When you give them a standard 300 milligram loading dose of Clopidogrel, their liver simply cannot convert enough of it into the active metabolite.
Wow.
So the resulting platelet inhibition is weak, it's delayed, and it's highly unpredictable.
This means a patient could be diligently taking their medication. The cardiologist firmly believes they are protected, yet their blood remains hypercoagulable.
Exactly. It's a false sense of security.
And the clinical consequences of that are catastrophic, particularly when we talk about stent thrombosis.
Stent thrombosis is one of the absolute most feared complications in interventional cardiology.
Because you're putting a foreign object into the heart, right?
Yes. When a doctor places a bare metal or drug-eluting stent into an artery, they're introducing a metallic cage into a highly reactive vascular environment. Until the body can grow a new layer of endothelial cells over those metal struts, which takes months. By the way, the stent is highly thrombogenic.
It's just begging clots to form on it.
Exactly. Without aggressive, highly reliable platelet inhibition, a massive clot will form directly inside the stent, causing an abrupt and often fatal myocardial infarction.
But let me push back on this for a second. If clopidogrel is already the standard of care and it objectively saves lives, aren't we just splitting hairs by searching for a replacement? Like, why risk introducing a totally new variable into emergency heart care?
I get that. It sounds like trying to fix something that isn't entirely broken. But when you apply slight variability to global populations, that slight delay or weak response translates to thousands of lost lives.
Right. The scale changes everything.
Exactly. Thousands of people having secondary heart attacks because they were poor metabolizers. The pharmaceutical industry knew it too, which perfectly tees up the need for a completely different pharmacological approach.
Like prasugrel.
Yes, they developed prasugrel. It's another drug in the thienopyridine class. It's also a prodrug, but its molecular structure allows it to bypass the most restrictive steps of that cytochrome P450 pathway.
So it works faster?
Much faster. It converts to its active metabolite consistently. But reading through the prasugrel trial data, specifically the Triton-TEMI-38 trial, it really seems like they overcorrected.
How so?
They engineered a drug that was incredibly potent at inhibiting the P2Y12 receptor, and it successfully plummeted the rates of stent thrombosis and ischemic events.
That sounds like a win.
It does, but the biological trade-off was brutal. Prasugrel was associated with an unacceptable increase in major life-threatening bleeding, particularly in patients who were older, had lower body weight, or had a history of stroke.
Ah, so it tipped the hemostatic scales way too far into hemorrhage.
Exactly. It was too strong for a lot of people.
Which perfectly sets the stage for the Plato trial. The clinical community is trapped in this Goldilocks dilemma. Clopidogrel is too variable and sluggish. Prasugrel is too potent and causes too much bleeding. We needed a molecule that completely circumvented the hepatic prodrug pathway, offered rapid onset, but didn't permanently destroy the body's ability to form a clot if a bleeding emergency occurred.
And enter Ticagrelor.
Let's talk about Ticagrelor, because unlike Clopidogrel, it is an oral, reversible, direct-acting inhibitor of the adenosine diphosphate receptor P2Y12.
Right. It belongs to an entirely new chemical class called cyclopentyltriazolotopyrimidines, or CPTPs for short.
Let's stick with CPTTs. My tongue is already twisting.
Fair enough.
Yep.
Its mechanism of action completely upends the old thienopyridine model. First, it is an active drug the moment you swallow it. There is zero hepatic biotransformation required.
So it just goes straight to work.
Yes, it absorbs into the bloodstream and immediately binds to the P2Y12 receptor on the platelets.
To really grasp why this matters, let's look at the P2Y12 receptor itself. It's a G protein coupled receptor. When ADP, or adenosine diphosphate, binds to it, it triggers this intracellular signaling cascade that lowers cyclic AMP levels and ultimately causes the platelet to express glycoprotein IBA receptor.
That's the exact pathway, yeah.
And those receptors act like chemical grappling hooks, allowing platelets to cross-link with fibrinogen and form a solid clot. Now, Clopidogrel and prasugrel's active metabolites permanently bind to this receptor. They are irreversible.
And that irreversible binding is a critical pharmacokinetic feature.
Yeah.
When clopidogrel binds to a platelet, that specific platelet is permanently disabled for the entirety of its 7 to 10-day lifespan.
It's basically dead weight at that point.
Exactly. The only way the patient regains normal clotting function is by waiting for the bone marrow to manufacture entirely new, unexposed platelets.
So what does this all mean? Think about clopidogrel's irreversible inhibition, like changing the locks entirely on a door. Once you do it, that old key is never working again. You have to replace the whole door if you want to get back in.
That's a good analogy.
Whereas Ticagrelor is more like hiring a temporary bouncer. The bouncer's highly effective, he's direct, he stops people from getting in, but he's willing to leave when his shift is done. It's reversible.
And the clinical implications of that reversibility are profound. Imagine an ACS patient who comes into the ER, gets loaded with antiplatelet drugs, but the angiogram reveals their coronary anatomy is so complex that they need emergency open-chest coronary artery bypass grafting.
A CABG procedure.
Right. If they are loaded with irreversible clopidogrel, the surgeon faces a nightmare scenario of operating on a patient who simply cannot clot.
It'll just bleed out on the table.
Exactly. But with Ticagrelor, the drug clears the system much faster, theoretically offering a much safer window for emergency surgery.
That brings us to the architecture of the Plato trial itself, because proving that a reversible, direct-acting molecule is superior to the entrenched standard of care, you can't just test that on 50 people. That requires a trial design of staggering proportions.
Plato was the study of platelet inhibition and patient outcomes trial. And massive is an understatement.
They recruited 18,624 patients. And they didn't just pull from a few academic hubs. These patients were spread across 862 medical centers located in 43 different countries.
The logistical execution of a 43-country, double-blind clinical trial is an astonishing feat of modern science.
I can't even imagine the paperwork.
Oh, it's endless. You are coordinating across 43 different regulatory agencies. You have to standardize inclusion criteria like being hospitalized for ACS, onset of symptoms within 24 hours, varying ECG and biomarker profiles across vastly different healthcare systems.
And physically moving the drugs around, too.
Right. Managing international cold chain drug supply lines and ensuring that an investigator in Warsaw and an investigator in Chicago are following the exact same protocol to the letter.
And the blinding process was incredibly complex because of the differing pharmacokinetics of the two drugs, right?
Yeah, you have a dosing mismatch.
Because Ticagrelor has a relatively short half-life due to its reversible nature. So it requires a 180 milligram loading dose followed by a 90 milligram twice-daily maintenance dose.
Exactly, 2 pills a day.
But clopidogrel, being irreversible, is given as a massive 300 to 600 milligram loading dose, followed by a 75 milligram once-daily dose, so 1 pill a day.
Right, and if you simply hand one group of patients a pill to take twice a day and the other group a pill to take once a day, the trial is instantly unblinded.
The doctors would know immediately who was on what.
And then the placebo effect creeps in, physician bias alters the reporting of side effects, and the whole data set is corrupted. So to maintain strict scientific integrity, they utilized a double dummy design.
Okay, a double dummy design, which means every single patient in the trial had to take the exact same number of pills at the exact same intervals, regardless of which group they were in.
Yes.
So if randomized to Ticagrelor, the patient took the active twice-daily Ticagrelor pills plus a visually identical placebo version of the once-daily clopidogrel.
And vice versa. The clopidogrel group took the active once-daily pill and 2 placebo Ticagrelor pills.
The sheer manufacturing and tracking effort to distribute these dummy pills across 862 centers without a single labeling error. I mean, that is a marvel on its own.
It really is.
Yeah.
But the logistics are only half the battle. The statistical framework driving the trial is what actually dictates its success or failure. This was an event-driven trial.
Meaning they weren't just waiting for the clock to run out.
Exactly. The researchers weren't just enrolling patients for a set amount of time. They were waiting for a specific mathematical threshold to be crossed. They calculated that to achieve 90% statistical power.
Wait, explain statistical power for the listener quickly.
Sure, it means a 90% probability of correctly rejecting the null hypothesis. Basically, being 90% sure that your results aren't just a fluke.
Got it.
To get that power, to detect a 13.5% relative risk reduction, they needed to observe exactly 1,780 primary endpoint events.
Let's unpack that because it beautifully illustrates the cold precision of these mega trials. The primary endpoint was a composite of death from vascular causes, myocardial infarction, or stroke. Based on historical data, the statisticians estimated that roughly 11% of the patients in the Clopidogrel control group would suffer one of those events within a year. So to prove with overwhelming statistical confidence that Ticagrelor was better, the trial literally had to run until 1,780 people across the globe suffered a heart attack, stroke, or died.
It was a sobering reflection on how medical evidence is generated. You build this billion-dollar apparatus, you enroll over 18,000 critically ill patients, and then you just monitor Kaplan-Meier survival curves in real time.
Waiting for bad things to happen.
Yeah, waiting for enough tragic events to accumulate so your p-values cross the threshold of statistical significance.
With the stage set and the sheer scale of the trial understood, the natural next question is, did this billion-dollar 43-country gamble actually pay off?
Let's look at those Kaplan-Meier curves and dive into the efficacy results.
Right. Did this pharmacological theory of direct reversible inhibition actually translate into human survival? The short answer is yes. At 12 months, the primary composite endpoint occurred in 9.8% of the patients receiving Ticagrelor, compared to 11.7% of the patients receiving Clopidogrel.
And that yields a hazard ratio of 0.84 with a p-value of less than 0.001.
It's just tiny.
It is. A p-value that infinitesimally small essentially eradicates the possibility that this difference was a random statistical artifact. The curves on the graph diverged early, within the first 30 days, and they continued to separate over the entire year. Ticagrelor was unequivocally superior at preventing subsequent ischemic events.
But looking at the breakdown, it wasn't just heart attacks that went down. The trial utilized predefined hierarchical testing for their secondary endpoint,
which is done to control for the family-wise error rate.
Meaning they tested endpoints in a strict pre-specified order so they couldn't just go fishing for positive data, right?
Exactly. You can't just pick the data that makes your drug look good. When they isolated myocardial infarction alone, it dropped from 6.9% with Clopidogrel to 5.8% with Ticagrelor.
And importantly, the stent thrombosis data strongly supported the drug's potency. For the thousands of patients who received a stent during their initial hospitalization, the rate of definite stent thrombosis dropped from 1.9% on Clopidogrel to just 1.3% on Ticagrelor.
So that direct, immediate P2Y12 blockade was successfully keeping those metal struts completely clear of platelet aggregation.
Here's where it gets really interesting, though. What separates Plato from almost every other trial in this space is the mortality data.
Yes.
The rate of death from vascular causes plummeted from 5.1% to 4.0%.
Yeah.
Even more staggeringly, the rate of all-cause mortality, meaning death from literally any reason, whether it be a massive stroke, cancer, or heart failure, dropped from 5.9% to 4.5%.
If we connect this to the bigger picture, I cannot emphasize enough how rare it is to prove a reduction in all-cause mortality in a modern cardiovascular trial.
Really? Why is that so hard?
Because most new drugs are being added on top of an already robust standard of care. These patients are already on statins, beta blockers, ACE inhibitors. Finding an additional survival benefit on top of that aggressive baseline is incredibly difficult.
You're trying to squeeze blood from a stone.
Yeah, exactly. The Ticagrelor trials, despite showing massive reductions in recurrent heart attacks, completely failed to show an all-cause mortality benefit. But Ticagrelor achieved it.
We do need to translate these numbers for the listener, though. To separate absolute risk from relative risk, a hazard ratio of 0.84 is a 16% relative risk reduction. That sounds massive in a pharmaceutical press release.
Oh, absolutely. They love leading with that number.
Right. But the absolute drop was from 11.7% down to 9.8%. That is an absolute risk reduction of just 1.9%. It might sound tiny to the listener. So tell us, what does that 1.9% mean when applied to the millions of people who suffer heart attacks globally every year? Let's talk about the number needed to treat, or NNP.
Sure. The number needed to treat is a vital metric for clinicians. To calculate it, you simply take the inverse of the absolute risk reduction.
So 1 divided by 0.019.
Exactly, which gives you roughly 53. That means a doctor has to treat 53 acute coronary syndrome patients with ticagrelor instead of clopidogrel for one entire year to prevent exactly one primary endpoint event.
One heart attack, stroke, or vascular death prevented for every 53 people treated.
Right. And treating 53 people to save one might sound inefficient to a layman, but when you zoom out to the epidemiological scale, it is paradigm shifting.
Because cardiovascular disease is the leading cause of mortality worldwide.
Yes. Millions of patients suffer an ACS every year. When you apply an NNT of 53 to a population of 10 million people, you're preventing nearly 190,000 catastrophic ischemic events. The macro public health impact is immense.
But, and this is a massive but, a drug that powerfully prevents clots inevitably raises a terrifying specter. If the blood can't clot, what happens when a patient starts bleeding?
This is exactly where the researchers held their breath. A hyper-potent antiplatelet drug risks turning a minor silent stomach ulcer into a fatal gastrointestinal hemorrhage, or a minor microvascular leak in the brain into a catastrophic hemorrhagic stroke. We have to look closely at the bleeding data.
So the primary safety endpoint was major bleeding, and the trial defined this using the Plato criteria, which categorizes bleeding based on clinical severity, fatal, life-threatening, or requiring significant transfusions.
And at the surface level, the overall rates of major bleeding were almost statistically identical, 11.6% for ticagrelor and 11.2% for clopidogrel. Not a statistically significant difference.
So it looks like the Holy Grail, a massive efficacy win without an overall safety penalty.
But surface data in a trial of 18,000 patients is often an illusion. When the statisticians decoupled the bleeding data and looked deeper, a highly nuanced, slightly alarming picture emerged.
Right.
They found a statistically significant increase in non-CGABG-related major bleeding with ticagrelor, 4.5% versus 3.8%.
So these are your spontaneous bleeds, the GI bleeds, the urinary tract bleeds that happen outside the operating room.
Exactly.
And drilling down even further into the supplementary appendix, there is a specific data point that demands extreme scrutiny. The critical trade-off: fatal intracranial bleeding.
Yes, bleeding inside the skull that directly causes the patient's death.
There were 11 fatal intracranial bleeds in the ticagrelor cohort compared to exactly 1 in the clopidogrel cohort. Now wait, I have to stop and push back on this entirely. On behalf of the listener, an 11-to-1 ratio for fatal brain bleed sounds terrifying.
It does.
How does a physician sit across from a patient who just survived a heart attack and say, I am going to prescribe you a new medication to keep your stent open, but you are 11 times more likely to hemorrhage into your brain and die. It's like driving a highly tuned Formula One car. It's brilliant at preventing a high-speed collision like a heart attack, but the steering is so sensitive that you risk a spin-out, a brain bleed. The psychological weight of prescribing a drug that actively causes a fatal stroke seems completely contrary to the Hippocratic Oath.
Your reaction perfectly mirrors the anxiety of the broader medical community when these tables were first published. This raises an important question: how do we evaluate harm? But a physician cannot practice based on emotional reactions to single data points. They must rely on the mathematical ledger of net clinical benefit.
Okay, walk me through the ledger.
Let's break down the denominator and the opposing side of that ledger. Yes, 11 fatal intracranial bleeds is a striking relative increase compared to 1. But those 11 bleeds occurred across an active treatment arm of 9,235 patients.
Wow, okay.
That is an absolute incidence rate of roughly 0.1%. It is a profoundly rare event.
Okay, so the absolute risk of the brain bleed is tiny. I get that. But how does the rest of the ledger balance out that 11-to-1 discrepancy?
You have to look at the other types of fetal bleeding. While ticagrelor caused 10 more fatal intracranial bleeds, clopidogrel caused 12 more non-intracranial fatal bleeds. These were mostly massive gastrointestinal hemorrhages or procedural bleeds.
Wait, really? Let me check the numbers. There were 9 intracranial fatal bleeds on ticagrelor and 21 on clopidogrel.
Precisely. So the mechanism of death shifted geographically within the body. Ticagrelor patients who bled to death were more likely to bleed in the brain, while clopidogrel patients who bled to death were more likely to bleed in the gut.
That is fascinating. So when you tally up all fatal bleeding events of any kind,
the rates are practically identical: 20 total fatal bleeds for ticagrelor and 23 for clopidogrel. The overall safety risk of bleeding to death was not increased. And when you factor that stable fatal bleeding rate against the massive reduction in vascular deaths and myocardial infarctions, the net clinical benefit overwhelmingly favors ticagrelor.
it's the ultimate biological trade-off. We are accepting a slight geographic shift in how rare fatal bleeds occur in exchange for a massive, undeniable reduction in the overall all-cause mortality rate. It proves that there are no perfect drugs, only carefully calculated compromises.
Exactly. Medicine is a game of probability.
But the bleeding profile wasn't the only thing that caught researchers off guard. Beyond life-threatening bleeds, the deeper data tables reveal some bizarre, unexpected quirks of the drug that baffled researchers at the time. Because ticagrelor is a completely novel chemical entity, a CPTP, it interacts with the human body in ways that clopidogrel simply does not.
Yeah, the non-bleeding adverse events recorded in the Plato trial revealed some fascinating, highly specific pharmacological quirks. The most prominent off-target effect was dyspnea.
Which is the clinical term for a subjective feeling of shortness of breath.
Right, and it occurred in a staggering 13.8% of patients on ticagrelor, compared to only 7.8% on clopidogrel.
Imagine the clinical scenario there. A patient just survived a heart attack, they are already hypervigilant and terrified, and suddenly the new pill you gave them makes them feel like they are suffocating. It sounds like a fast track to medication noncompliance.
Oh, absolutely. Patients will just stop taking it.
But why does a blood thinner affect the lungs? That doesn't make intuitive sense.
It's a brilliant example of how complex cellular signaling is. Ticagrelor doesn't just block the P2Y12 receptor. It also exhibits an off-target effect where it inhibits something called the equilibrative nucleoside transporter 1.
Or ENT1. And ENT1 is responsible for clearing adenosine out of the extracellular space, correct?
Exactly. By blocking ENT1, ticagrelor increases the localized concentration of adenosine in the blood. And adenosine is a powerful signaling molecule.
Right.
When those elevated levels of adenosine reach the lungs, they stimulate the vagal T fibers in the pulmonary tissue. The brain interprets that specific vagal stimulation as dyspnea, even though the patient's oxygen saturation levels are perfectly normal.
That's wild. Their lungs are working fine, but their brain is being tricked into feeling short of breath by the accumulated adenosine.
Yep, it's a neurological illusion, basically.
And that perfectly explains the other bizarre anomaly in the safety data. The researchers used Holter monitors, those continuous portable ECG machines, on a subset of about 3,000 patients to track their electrical rhythms.
And they found something very interesting.
Yeah, they discovered that patients on ticagrelor were significantly more likely to experience ventricular pauses of more than 3 seconds during the first week of therapy. Their hearts were literally skipping beats.
Yes, and that is also directly mediated by the elevated adenosine levels. Adenosine has a profound transient depressing effect on the atrioventricular, or AV, node.
Which is the electrical gateway between the top and bottom chambers of the heart.
Right. The localized adenosine accumulation was temporarily blocking electrical conduction, causing those asymptomatic 3-second pauses.
It's incredible how mapping these off-target side effects, the shortness of breath, the skipped beats, even the slight increases in uric acid and creatinine, it paints a complete biochemical portrait of the drug's collateral impact on the ENT1 transporter. It is pure pharmacological detective work.
It really highlights how interconnected our biology is.
But bringing these granular scientific anomalies back to the listener's everyday life, the most compelling mystery of the entire Plato trial wasn't found in a cellular transporter. It was found deep in the statistical subgroup analysis.
What's fascinating here is how they handled the data. To ensure the robustness of their findings, the trial investigators created a forest plot, slicing the 18,000-patient cohort into 33 distinct subgroups.
33 different ways to slice the pie.
Yeah. They tested the drug's efficacy based on gender, age, weight, diabetic status, baseline medications, and geographic region. And in almost every single subgroup, the data points fell heavily to the left of the hazard line, meaning ticagrelor was universally superior.
Except for 3 distinct subgroups where the benefit basically vanished. 2 of them, patients weighing below the median, and patients not on lipid-lowering drugs, were interesting, but likely tied to altered pharmacokinetics or baseline risk profiles.
Right, there were biological explanations for those.
But the third anomaly set the cardiology world on fire. The superiority of ticagrelor completely disappeared in patients enrolled in North America. The p-value for interaction was 0.045. I mean, look at this realistically. Did the drug just get jet lag crossing the Atlantic?
Oh, it does sound absurd.
Why would a pill work differently in Chicago than it does in Stockholm? A patient suffering a STEMI in a hospital in Warsaw is biologically indistinguishable from a patient suffering a STEMI in a hospital in Chicago.
It is arguably one of the most famous geographic anomalies in the history of clinical trials. And interpreting it requires looking through 2 distinct lenses: the lens of statistical probability and the lens of localized clinical culture.
Start with the statistics.
Statistically, when you perform multiple comparisons, like slicing a single data set into 33 subgroups, You exponentially increase the risk of a type I error, which is a false positive. By pure mathematical chance, if you flip a coin enough times, you will get a bizarre streak.
Right.
So many statisticians argue the North American anomaly was nothing more than a mathematical ghost.
A ghost in the machine. But you don't just write off a major geographic region in a billion-dollar FDA submission by shrugging and blaming the math. The investigators had to act as clinical detectives. What was the hidden variable? What was structurally different about how a cardiologist in the United States treated a heart attack in 2008 compared to a cardiologist in Europe?
And the answer lay not in the high-tech interventions, but in one of the oldest, cheapest drugs on the planet, aspirin. The trial protocol mandated that all patients receive aspirin alongside their assigned P2Y12 inhibitor. But crucially, the protocol allowed local investigators to choose the maintenance dose of that aspirin based on their local clinical guidelines.
And this exposes a massive cultural divide in global medicine. In Europe, the prevailing clinical philosophy was less is more when it came to aspirin. They routinely prescribed low-dose maintenance aspirin, typically 75 to 100 milligrams daily, to balance platelet inhibition with GI safety.
Right, keep the dose low to prevent ulcers.
But in North America, there was a deeply entrenched, almost dogmatic tradition of prescribing high-dose aspirin, 325 milligrams, every single day.
That 325 milligram dose was a relic of older trials and a uniquely American more is better medical culture. When researchers cross-referenced the North American patient data with the aspirin dosing data, a massive correlation emerged. The loss of ticagrelor's efficacy was entirely concentrated in patients taking high-dose maintenance aspirin.
Mechanistically, why would high-dose aspirin neutralize ticagrelor? We know aspirin inhibits COX-1 to stop platelets, but high doses also start to inhibit COX-2 in the vascular endothelium. And COX-2 is responsible for producing prostacyclin, which is a natural vasodilator and a powerful endogenous inhibitor of platelet aggregation.
Exactly. The leading mechanistic hypothesis is that the massive 325 milligram daily doses of aspirin were effectively shutting down the body's natural prostacyclin production. Ticagrelor is so potent that it might actually rely in part on that baseline endothelial prostacyclin to achieve its maximal clinical benefit.
Oh.
Yeah, by hammering the endothelium with high-dose aspirin, the North American doctors were inadvertently blunting the synergistic effect of their new billion-dollar drug.
That is a profound realization. It means that the success of a cutting-edge, precision-engineered CPTP molecule was fundamentally derailed by an outdated, localized habit involving a 2-cent over-the-counter painkiller. It actually forced the FDA, when they eventually approved Ticagrelor, to include a strict black box warning that maintenance doses of aspirin above 100 milligrams should be avoided when taking the drug.
That anomaly brings the massive abstract mathematics of the Plato trial crashing back down to the reality of everyday clinical practice. It highlights how intertwined our pharmacological interventions truly are.
You can't just change one thing.
Right. You cannot alter one profound pathway like the P2Y12 receptor without considering the cascading effects on ENT1 transporters, prostacyclin synthesis, and the entire hemostatic balance of the patient.
Which perfectly synthesizes the core message of this deep dive. Let's talk about the relevancy for the learner here. The Plato trial isn't just about proving ticagrelor is better than Clopidogrel. It's a lesson in how medical truth is established.
Absolutely.
It requires 18,000 plus people, immense logistical effort, and a willingness to accept nuanced trade-offs like dyspnea and isolated bleeding risks for a broader societal survival benefit. It's a testament to the evolutionary shift in how we approach medicine. For decades, we relied on blunt instruments prodrugs that depended on sluggish liver factories and highly variable genetic profiles. We accepted irreversible biological changes because we simply didn't have the technology to do better.
Ticagrelor really represents the transition to precision pharmacology. We are designing molecules that bypass the metabolic middlemen. They bind directly, they act immediately, and crucially, they maintain the flexibility of reversibility. But as this trial exhaustively detailed, precision does not mean perfection. I'd encourage you, the listener, to think critically the next time you read a medical headline. Look past the primary endpoint and ask about all-cause mortality, subgroups, and the inevitable physiological trade-offs.
Yeah, biology always extracts a toll. Getting the heart to survive a catastrophic ischemic event means we must accept the deeply nuanced trade-offs. Medicine is moving from blunt instruments to precision tools. We are designing drugs that do exactly what we want, and thanks to reversibility, they stop acting when we need them to. But we accept the transient ventricular pauses. We accept the adenosine-mediated shortness of breath. We navigate the terrifying razor-thin margin between preventing a clot in a stent and triggering a fatal hemorrhage in the brain.
It's all about finding that balance.
As we wrap up our exploration of the Plato trial, I want to leave you with a final, provocative, lingering thought. Think back to that North America subgroup anomaly we just discussed. It leaves us with a fascinating, unanswered question to mull over. In our age of highly standardized, meticulously controlled, globalized medical research, how much do seemingly minor, entrenched local habits, like a doctor's stubborn preference for a slightly higher dose of a century-old, over-the-counter painkiller, silently dictate the success or failure of the next generation of life-saving innovations?
It's a humbling thought for sure.
It proves that no matter how sophisticated our clinical trials become, the human element, our culture, our habits, and our genetic variability will always ensure that the landscape of medicine remains challenging to navigate. Thank you for watching The Funnel Effect.